I'd like to welcome all of you to our pediatric grand rounds. I believe this is going to be our last grand rounds for the fiscal year, and we'll be taking a break over the summertime and reconvene after the summer break. I think it's very fitting that this grand rounds is dealing with a topic that has been on the minds of many of us over the last couple months. And I'm glad that we were able to have an outstanding speaker today to help us address some of the issues. And so I'd like to turn it over to our Vice Chair for Education, Sandrine Van Schaik, to get our program started for today. Sandrine.
Thank you, Dr. Hirsch. I can tell that your mind is with economics as well as with our current state focused on anti-racism, since you're talking about the last grand rounds of the fiscal year. I think we're thinking of it as the last grand rounds of the academic year, but they overlap, and it certainly is. And I'm really pleased that we've been able to pull together a special grand rounds that will be longer than our regular grand rounds. We have 90 minutes. If you can't stay for the full 90 minutes, the last half hour is really meant to have a panel discussion with some people at our institution that are very engaged in diversity, equity, and inclusion work. But we're going to start off with our keynote speaker, who is a really special guest for very many reasons. First of all, she is a phenomenal person, really exceptionally talented physician, advocate, and someone that has a lot of important things to say about the topics that we're going to address today, with recent publications in the Lancet, New England Journal of Medicine, and also a recent testimony on a hearing for the House Committee on Energy and Commerce. So really a national voice in this. I'm talking about Dr. Rhea Boyd. What makes Dr. Rhea Boyd also very special is that she's a graduate from our own pediatric residency program, which is actually how we knew each other, and always managed to cross paths even after she graduated residency. So she is clinically now employed by the Palo Alto Medical Foundation, where she is in the where she practices primary care. She is nationally very well known. She teaches on the relationship between structural racism, inequity, and health. And she has a lot of experience in advancing community-based advocacy. She leads efforts to characterize and address the child and public health impacts of harmful policing practices and policies. And she serves as the Chief Medical Officer of San Diego 211, working with navigators to address social needs of San Diegans impacted by chronic illness and poverty. She's also the Director of Equity and Justice for the California Children's Trust, which is an initiative to advance mental health access to children and youth across California. And a bit more about her background, because in addition to being a graduate from our residency program, she graduated cum laude with a BA in Africana Studies and Health from the University of Notre Dame, then earned her MD at Vanderbilt University School of Medicine before coming for a residency here. And then in 2017, she graduated from the Commonwealth Fund Morgan Minority Health Policy Fellowship at the Harvard University School of Public Health, and earned an MPH through that program. So very talented, very experienced in advocacy, very knowledgeable in the area of anti-racism, policing practices, etc. And we were so pleased that she accepted this invitation to come speak to us today. And with that, I'm handing it over to Dr. Boyd.
Hi, everyone. Let me do a quick screen share so you can see what I'm looking at too. Okay, perfect. It is really an honor to talk to y'all again. We are family. Y'all know me personally. Y'all were with me as I struggled through residency. and y'all have been some of my biggest cheerleaders and co-conspirators in my work post-residency. So I love talking to y'all. And I'll say, a lot of people have asked me to talk on these topics, and I'm gonna say things to you guys because we're family that I haven't been saying everywhere. And so I hope as we move into the Q&A part of this, that we can have a really rich and honest discussion about what's happening in our communities. Specifically, we're going to talk about the intersecting forms of violence that are threatening and shortening Black lives right now. We're going to focus on Black lives, but we're going to also talk broadly about the impact of COVID-19 and policing on communities of color and also on all Americans. And I put my Twitter handle at the bottom. It's always an easy way to reach me or to share resources with me. So first, I'm not really being paid for what I'm going to say today, although because of the Wonderful Plus program and colleagues like Jyoti and Anda, I do have paid positions in advocacy, which is a future possibility for all of you trainees and residents listening in. And I'm also happy to talk about that more offline. So what are we going to talk about today? We're going to open up by talking about the pre-existing inequality that existed in America that the COVID-19 pandemic happened on top of. We're going to then talk specifically about whiteness. And I think it's really important to talk about because we're going to talk about the racial and ethnic disparities that have emerged amid the COVID-19 pandemic, but we can't leave out the fact that white is also a race and white folks have also been affected. And so we're going to talk about how we can understand that. And then we're going to close by talking specifically about policing and its effect on health and why protest is a vital public health intervention. So let's jump in. We're going to run through some slides really quick that talk specifically about our healthcare system. So what we know in healthcare is that the needs of our complex patients change over time, but most of our healthcare models are static. And I call that our box. The box represents the constraints that we placed around what we call healthcare, essentially, and what we should be doing as healthcare providers. But we know that those constraints only contribute to about 10% of major health outcomes like premature death, which is that little figure on the right. Despite only contributing to such a small amount of critical health outcomes like premature death, we pour a ton of money into our healthcare box, more than any other OECD nation or wealthy international peer. For that, we have the worst health overall compared to all of our peer nations. We have lower life expectancy, higher infant mortality rates, higher rates of chronic illness, and higher rates of diseases like obesity, despite our population being relatively younger than our OECD peers and being less likely to smoke, although the vaping epidemic is changing our smoking rates. What that means is for each additional dollar that we poured into our healthcare system, we are now losing in life expectancy. We are bending the curve the opposite way. And so a recent paper from JAMA in 2018 showed us that if you follow this curve off of 2014, it's actually bending down now, where for the last 3 years, life expectancy has decreased in the United States. Why is that? Researchers Elizabeth Bradley and Lauren Taylor compared the investments the United States makes versus our other OECD nation peers in healthcare versus social care. And what they found is that we don't invest in our broad social safety net the way we invest in healthcare. And that's what makes us an outlier. Because of that, inequality is growing. And we in California are not immune. We lead the trend. We are now the state that has the highest poverty rate. This is using the supplemental poverty measure, which takes into account the cost of living in your state, which is different than the federal poverty line, which doesn't. And so using the supplemental measure, we have the highest rate of poverty in the country. Nationally, what that means as inequality grows is that we are a part of a generation where half of our kids will not earn more than their parents. As you can see from this chart, this is an aberration in the last half a century. And we know that it's not racially distributed the same. So this is a map that I show in every presentation I give now, and it looks at economic mobility in our country by race and by gender. If you look at the green map, what it essentially shows is that it pays to be a white boy who grows up to be a white man in the United States. because virtually everywhere he lives, he is likely to earn more in adulthood than his parents did when he was a child. Conversely, if you go to the red and orange map, you can see that it's essentially not safe to be a Black boy who grows up to be a Black man anywhere in America, because nearly everywhere he lives, he is likely to earn less in adulthood than his parents did when he was a child. As the researchers summarized, in 99% of neighborhoods across the US, Black boys earn less in adulthood than white boys, despite growing up in families with comparable incomes. But the researchers controlled for more than just comparable incomes. These were also families that had two parents, families that had comparable levels of education, families that had comparable wealth, and that lived on the same city block, and their kids went to the exact same school. What does this mean? It means that although some of us may say we're not surprised that African Americans, and particularly Black boys, have lower rates of economic mobility than white boys, that usually we attribute that lack of surprise to things like segregation, or even going all the way back to slavery. But we think of like redlining and how it contributes to the racial wealth gap. But this controlled for the wealth gap. We think of how segregation contributes to segregation in education. These kids go to the same school. They live on the same block. And so what is it? They found that the gaps in mobility are smallest, or the most narrow, for little Black boys and little white boys who live in areas with low racial bias among white folks, where white people are less racist, and where there's high father presence in Black neighborhoods. That's not father presence in your home, that's Black fathers on your city block. So we also have to think about the forces that extract Black men, and Black fathers in particular, from Black communities. And we absolutely have to think then about the school to prison pipeline, mass incarceration, and police violence. And when we think particularly about white racism, we have to think about how casual racism, like quote unquote barbecue Becky or even Amy Cooper, contributes to the weaponization of public spaces such that folks call police on Black people just for living and trying to enjoy a public space. And that call to the police is a known threat to folks' lives, and it threatens taking Black folks and Black fathers particularly out of their communities. And that the downstream effect has an intergenerational effect on mobility in Black communities. So when folks talk about returning to normal, it's important that we contextualize the normal that we're referring to, because this is the pre-existing inequality that existed in America when COVID-19 struck. And if we now look at hotspots for COVID-19 in the country, we see it maps really closely to the gaps in economic mobility that exist by race and gender in this country. Specifically, if we look at CDC data, we see that death rates from COVID-19 are the highest for African Americans, Latinx, and certain Asian subpopulations, particularly here in California for Native Hawaiian Pacific Islanders. And although the numbers don't shake out in this figure, there have also been disproportionate amounts of cases and deaths among indigenous populations, particularly Navajo Nation. This is also true for kids. As pediatricians, I think the current accepted wisdom is that kids don't seem to be as affected. They don't, if they have COVID, seem to have as severe of symptoms. And yet, if you go to the CDC website, as I just did, you can see that there are also disparities already emerging for death rates among African American and Latinx youth, particularly those who are 15 to 24. This is something that we all need to watch. Now, if we look at deaths by county, this is data that came out of Harvard's School of Public Health. We see that the mortality rate for COVID-19 is 6 times higher for Americans who live in counties that are predominantly non-white as compared to Americans who live in counties that are predominantly white, which is the difference between that 17 and that 2.8. This is particularly true for majority Black counties, as the Washington Post reported. Overall, Black Americans have the highest mortality rate from COVID-19. It's more than 2 times any other racial or ethnic group in the country. So the question is, are these disparities, are these just differences or are they inequities? So inequities are population level differences in health that are preventable. And because they're preventable and unfair, they are then unjust. And so we're going to talk about these disparities as inequities. How do inequities happen? Health inequities arise when certain populations are made vulnerable. I put that in bold because this is really critical. People aren't innately vulnerable. The structural conditions in which we live render people vulnerable to illness and disease, usually through the inequitable distribution of protections to keep people from getting sick and the inequitable distribution of supports to ameliorate sickness and to address the consequences, socially, economically, politically, of being sick. So how should we place that in terms of this current pandemic? Early on, evidence suggested that risk factors for having more severe illness or premature death from COVID-19 include chronic illnesses like heart disease, diabetes, hypertension, or asthma, and age. But then as we started to see the racial health inequities emerged, we had to then ask questions about how segregation affects one's risk for something like heart disease, for example, or about how chronic exposure to discrimination leads to increased rates of hypertension among communities of color, particularly Black communities. We have to ask about how toxic stress affects asthma rates in communities of color, how the racial wealth gap disallows communities the economic resources they need to adequately treat chronic disease, how allostatic load and the chronic exposure to stress and stress hormones actually weathers or ages your cells such that your chronological age is different than your cellular age. And if your cellular age is older, you may experience higher rates of chronic illness like the ones listed here, and also premature death. And environmental racism, and how the disproportionate exposure to toxins and pollutants in communities of color increases rates of chronic illness like asthma. These are examples of how structural racism shapes the opportunities for communities to be well and provides conditions for communities to have increased amounts of disease. As Kamara Jones calls it, structural racism should be understood as inherited disadvantage. So what does that mean? It means the conditions in which our families and our patients live, work, learn, and grow, those conditions shape their intergenerational population health, not just the health of our patients as kids, but the health of their kids and their kids as well. What are examples of this? We're going to look at 3. So hand washing, we all know, is one of the most critical and important ways to limit the exposure to and spread of infectious disease. And yet race in this country is the strongest predictor of access to clean water. African Americans and Latinx populations are twice as likely to lack access to clean water in their homes as white households. And Indigenous populations are 19 times more likely to lack access to clean water as white households. Here, structural racism is functioning through residential segregation and public divestment in communities of color, particularly Indigenous and Black communities, to exclude them from access to clean water. And that then places them at increased risk for exposure to and spread of COVID in their communities. What's another example? We talked about environmental racism. There was a study that came out early in the pandemic that showed that chronic exposure to particulate matter in the air, like air pollution, actually increases communities' COVID-19 mortality rate. But we know that residential segregation, suburbanization, white flight, and zoning ordinances profoundly shape the exposure to air pollution in communities of color, particularly Black communities. And that means those factors are drivers of the increased COVID-19 mortality rate in those communities as well. We also have to talk differently about age. We used to say at the beginning of this pandemic, wear a mask to protect your grandparents. And then researchers at Harvard School of Public Health released data that said the largest gap in COVID-19 mortality between racial groups is between Black Americans and white Americans aged 35 to 44, where Black Americans have a 9 times higher mortality rate. 9 times. If you were to go 10 years below to Black Americans and white Americans aged 25 to 34, it's 7.3 times, right? So when we say that age is a major risk factor, we don't account for the cellular aging that's happening to communities that are chronically exposed to discrimination and the stress that that causes. So chronic discrimination also ages folks. And so we, as public health advocates and as clinicians, have to talk differently about age as a risk in this current pandemic. So what does that mean? It means the risk of COVID, and I put a star by risk because I want us to think not at the individual level where individual behaviors might potentially increase someone's risk for infection. Instead, we're thinking at the population level, where populations are systematically made more vulnerable. And so the systematic drivers for communities of color are not simply summarized by words like poverty or underlying illness. Instead, they reveal legacies and current practices of racial exclusion, discrimination, disinvestment, and violence that concentrate disadvantage, create adversity, and shape population-level opportunities for health and provide conditions for disease. I have also put this slide up everywhere. I said this in my testimony, written and oral, to our Congress. Please take this slide and use it and never say again that what's happening to folks is just because they tend to be sicker or they tend to be poorer. It is much more complicated than that, and we have to be really nuanced in our language so we know exactly what interventions we need to target. But these are the factors that also contribute to African Americans having higher rates of mortality from nearly all causes. Similarly for Indigenous Americans and for white folks. So now we're going to dip into what's happening with white folks. So this is data from 2015 that really caught everyone's attention. It was from economist Case and Deaton, and they won a Nobel Prize for this, where they indicated that that red curve going up, USW stands for US whites, that the mortality rate of US whites was bending the opposite direction. It was increasing, which was really an aberration for any developed nation in the world, and they compared US whites to other OECD nation peers. But, and again, they won a Nobel Prize for this, but the highest mortality rates by far longstanding in this country have been for African American and Indigenous populations. So this is data from JAMA from 2018 or 19 that then looks specifically at white mortality rates, which is that light blue curve in the bottom, and overall US mortality, which is the darker curve in the middle that has the squares on top of it. Those squares are indicating when the curve shifts. And you can see around 2009 and 2014, the curve starts to trend up for our country, which is why now life expectancy is trending down for our country. But that curve is not just driven by white deaths, it's also absolutely driven by the increase in Indigenous deaths and Black deaths as well. So let's spend a minute just talking about whiteness, because I think this is really important. I think too often in our practice, whiteness is accepted as normative. And so it's absently present. It's shaping all of our systems and many of our racial health inequities, and yet we never quite name it. So what is it? White is the racial status, right? It's a racial status that's affixed to a phenotypic skin tone. But whiteness is the structural apparatus in which that status functions. It's the laws and policies that give that racial status meaning and advantages by empowering, normalizing, favoring, and rewarding white folks as a population. This is really important. It's not about individual levels. Again, we're thinking systematically at the population level. So what do I mean when I say whiteness? I'm referring specifically to white hegemony, white supremacy, white privilege, and white normativity. And we're going to define each of these words so that we can use them in our discussion today. So white hegemony refers to practices of racial exclusion and discrimination that establish and enforce racial hierarchies in which white people nearly exclusively hold decision-making power. White supremacy refers to practices of racial exclusion and discrimination that create and maintain a racial ordering of human resources such that it reinforces white racial dominance. This is usually done either through violence, which we've seen, or deprivation. White privilege refers to the practices of racial exclusion and discrimination that preference white folks through disproportionate access to resources associated with mobility. And white normativity refers to the practices of racial exclusion and discrimination that naturalize the power asymmetries that then exist between white folks and non-white folks as being primarily meritocratic, as primarily white folks deserve it more than other folks. This is a book that I reviewed in the Lancet back in January by Jonathan Metzl. I highly recommend it. In this book, he essentially posits that whiteness is killing white Americans. What he says, and I absolutely agree, is that whiteness and the structural racism it engenders at a population level in the United States to shift resources to advantage white communities and disadvantage non-white communities has an ill health effect on everyone in the United States. One example of that is what's happening with states prematurely reopening. As white folks took to their state house lawns to then say, we want to protect the environment, or we want to protect our jobs, or, you know, we're worried about the economy, or we want to protect our freedoms, and lobbied to have governments reopen early, it identified their personal investment in their own whiteness and the freedoms that it allows them to traverse public spaces openly without any regulations, even regulations that are in their own interest and in the interest of everyone's public health. This is a headline that I just took from the LA Times back in May. So then you can similarly look at states that had protests and states that prematurely reopened, and you can see where cases are increasing across the country. This data is again taken from the New York Times. These are also states that were premature to close. So states that are early to reopen and premature to close are also states that have large proportions of their population that are white. I mean, overall in our country, more than 50,000 white folks have died from COVID-19. And while proportionally Black folks have the highest death rate, with absolute numbers, white folks have had the highest rates of death, the highest numbers of deaths, excuse me. And so what that means is the narrative that we have to carry as a society is not simply that COVID is deadly to Black and brown folks. COVID is deadly to everyone. And we need to make sure our public health messaging identifies that for folks so that they appropriately assess the risk and invest in everyone's health, not simply their own economic freedoms. So let's talk a bit about policing. Sometimes when we think about the inequality that pre-existed in our country that COVID-19 then happened on top of, I think we sometimes think about these forms of segregation, where there were separate public facilities based on folks' race. I think we less often think about this image. This is a picture of a little Black boy in Newark, New Jersey in 1967. This was the long, hot summer of 1967 that was named that way because there were 169 race riots across the United States that summer. Those race riots started because of an incident of police brutality against a Black taxi driver. What we don't often talk about when we think about inequality in this country is what it feels like to be a little Black boy walking down your city block with your own government at your back and your hands up because you know you're not safe. What we don't talk about is what it's like to be the folks who are lining the sidewalks, watching this happen to this little Black boy and not being able to intervene for fear for their own safety. And what we don't often talk about is that that legacy persists today. This is a Pulitzer Prize-winning image that covered Time magazine in 2015 from Baltimore after the murder of Freddie Gray. I have seen more recent images that use the same picture and cross out 2015 and put 2020. What we don't talk about is what it feels like to be the victim of police surveillance and violence century after century after century. So when we think about what causes risks for COVID-19, and we go through all of the different factors that contribute, we have now got to start thinking about police violence as one of the factors that also drives chronic disease and illness in communities that will also render communities more vulnerable to COVID-19. So what do we know about police violence? We know that nearly 1,000 people are killed by police every year in this country, and that exposure is most deadly for Black folks, Latinx folks, and Indigenous folks. Data from the National Academies of Sciences in 2019 told us that the lifetime risk for Black men and boys to be killed by police is now 1 in 1,000. I always say this figure to pediatricians because 1 in 1,000 is also the mortality rate of measles. And when you think about the near constant public health surveillance and investment we have put into measles prevention because we deem it that deadly, and you compare it to the near nothing we have invested as a national public health infrastructure into preventing police violence, you start to see how structural racism not only shapes community level exposures, but shapes our public health responses in this country and neglects certain communities, leaving them vulnerable to illness and early death. If we just look at data here from California, this is from our open data portal, and we're lucky to be one of the states that has this. You can see that African Americans and Indigenous populations are overrepresented among those who have deaths in custody. So anywhere where you see that light blue bar that's bigger than the dark blue bar beside it, that means you have a higher rate of deaths in custody than you do of your percentage of the population. Deaths in custody, I'll also just mention briefly, refer not just to deaths in a police encounter, but also as that encounter begins. If you die, for example, in a police chase and there's a car accident or a shootout, or after the police encounter, if you die in jail or from chronic illness while you've been incarcerated. When we think about police use of force and violence, though, we have to think about the consequences beyond death, because the actual more common injury is serious bodily injury. And this is, again, data just from California, from the most recent year it's available, 2018. But we also have to think about what was the reason police even came to the scene in which force was used. And I always show this slide because it's devastating. In 50% of the cases in which force was used, and remember, 1/4 of those cases in which force is used, someone's going to die. And 50% of the time in which force is used, someone's going to suffer a serious bodily injury. Half of the time police showed up, it was because someone called for help. This is why we're having a national conversation about what public safety looks like. Because if 1 out of 2 times you call for help, somebody's seriously injured, and 1 out of 4, somebody dies, we can no longer call that institution one that's keeping us all safe at the same rate. And that's why people are making calls for defunding the police and shifting that funding to more caring, mutually aid infrastructures like we may have in healthcare. So we know that police violence certainly risks the health of the direct victim, right? They are at risk for injury, disability, death, mental health impairments. They're also at risk for all of the harms and ills associated with incarceration and arrest. But witnesses are affected too. Witness violence has a long history of study in pediatrics in particular and in public health literature, as does witness police violence. And we know that kids particularly who witness police violence, either virtually through their cell phones or TV media or just secondhand accounts, witness violence increases rates of self-reported poor health and mental health impairments like PTSD and depression, and poor school performance and early school failure. There's also a study back in 2018 from The Lancet that was really profound, that found if police kill 1 unarmed Black American in your state, it impacts the mental health of every Black American who lives in your state. Right? So if we're thinking about what kind of a public health response is commensurate to one event of police violence, that response needs not just to respond to the individual victim or their direct family or the bystander witnesses, but every person in that state. Because the size of this mental health burden they found is analogous to the size of the mental health burden of actually having diabetes. And we have to just think about that for a second, right? Diabetes is incredibly debilitating. Some people will lose limbs when they have diabetes. So it's one of the chronic conditions that's associated with pretty severe mental health impairments. And having police kill one unarmed Black American in your state creates the mental health burden of you actually having diabetes. It's profound. And then this slide I honestly just made from a paper that was just pre-released today because it's so critical that we also understand the physical health effects of police violence. Dr. Sewell is one of the most preeminent writers in our country who publishes and studies on the health effects of police violence. And her most recent paper looks at what are the health effects or the spillover effects on the physical health at the neighborhood level for Black folks that have police kill somebody in your neighborhood. And what she found is that there are higher rates of high blood pressure and obesity in neighborhoods where police kill Black folks, and that this effect is particularly true for women. And we don't often talk about the gendered impacts of police violence, but it is absolutely true that women, and Black women in particular, suffer downstream physical and mental health impairments because of police violence in their communities and in their states. For children in particular, police violence can be experienced as caregiver absence, or a shift in who has primary custody, or as their own criminalization or the criminalization of their peers, which shapes their relationship to their own racial identity, which we call racial socialization. And so we also have to think about how often our children interact with police and the severity of those interactions to help capture the long-term stress and loss they may be experiencing that might also contribute to their ill health effects in the future. Parental imprisonment is also one of the adverse childhood events. We know that for kids who have a parent who's been incarcerated, they have increased rates of mental health impairments like depression and anxiety, and also physical health impairments like asthma and chronic headaches. We also know that if a parent's incarcerated, it also disconnects families from critical social determinants of health, like access to employment, public housing, student loans for their parents, and in some states, the access to vote. And as this election comes up, we all know that access to voting is going to be critical for communities of color. So what does that mean? It means police violence disappears caregivers, and that separates children from that primary attachment figure that they rely on for their physical development in the early years and for their thriving throughout their lives. So if this is the normal that folks have been wanting to go back to, we also have to think about how that normal is being exacerbated in this current moment. So since COVID-19, more than half of Black adults have now lost their job. So while the economic toll has been profound across the country, it has also disproportionately affected Black folks. We also know that Black folks have long had the highest unemployment rate in the country. And although there were national reports from our federal administration that the unemployment rate was going down, it has gone up for Black folks. You can only say that if you completely ignore the 0.1% increase in unemployment for Black folks since April. Right now, Black Americans have an unemployment rate that's at 16.8%. It's the highest of any racial and ethnic group in the country. And unemployment affects health. Long-term unemployment increases folks' risk for mental illness, and it increases folks' mortality rate. So even right now, during the COVID-19 pandemic and the economic burdens that have been created by the pandemic, those economic burdens are feeding back into risks for increased premature mortality and illness that will also increase communities' burden of COVID-19 and premature death. So what's the take home? The take home is racism kills people. And if we have built a box in medicine, we have to open up what we think our tools are to address racism. Because whatever we put in that biomedical box is not enough. And we've known that for decades. If racism kills people, we also know that equality saves folks, right? Equality, social, economic, political equality saves people's lives. It protects them from the discrimination that causes chronic disease, and it gives them equal access to resources that are vital for survival. When you know that equality saves lives, you then know that protest is a profound public health intervention, because protest in this country is one of the primary mechanisms by which we have progressed towards equality. It's what brought us the Civil Rights Act. It's what brought us protections for our workplace. It's what brought us women's liberation, right? Like, Black protest in particular is not an accessory to movements for liberation in this country. It is the root of women's liberation, of queer liberation, and of liberation in many of our work and public spaces. And so we have to support that protest when we can. I will also say that we shouldn't force protest to be the moment, right? People should not have to go into the streets for us to say you deserve rights and resources, but we have a tradition of doing that in this country. And so we're at that moment now. And so we in healthcare also need to support protesters, build medic tents, offer free testing at protest sites, right? Offer free masks and hand sanitizer to ensure that this critical act of civil unrest is protected so that our patients can have the equality they need to survive. So where do we go from here? This is a slide I'm sure everyone has seen where we talk about how equity is better than just plain old equality when we talk about interventions, and how liberation is even better than that. I'll give you some examples of things we can do right now. Equality would look like universal healthcare. We have got to remove insurance as a barrier to healthcare access, because we know it also is a way to tier care and to racially segregate care within our system. So we need universal healthcare, not just universal insurance. But even with universal healthcare, folks would still have barriers to accessing care. So during the COVID-19 pandemic, we need to universally test populations that have been plagued by the ails of segregation. If you have lived in a community that's racially segregated, that means you're more likely to be exposed to environmental pollutants. That means you have higher rates of chronic underlying illness. That means you have long been cut off from access to healthcare infrastructure. We need to go in and universally test folks there, not wait till they make their way into our drive-up clinics, many of whom may not even have a car, right? We need to go to them. We also need to think beyond just what happens in a healthcare infrastructure, and we need to advocate as healthcare providers for mandated worker protections, things like paid sick leave, living wages, hazard pay, liability insurance, things that will ensure that as people return to their jobs as essential laborers, that they have the protections that will keep them from being exposed to COVID-19 and COVID-19 spread. Because as we saw, most of the essential workers in this country are folks of color, particularly women of color, and they did not have the PPE they needed to stay protected early on in this pandemic. And if I'm going to suggest what's next, I absolutely think it's love. Equity is just the beginning. Just trying to redistribute resources based on need is just the beginning. If we are a system built on care, we actually have to love folks. And one example of what I think that could look like is sharing PPE. So if our workforce is predominantly white at every level, which it is, student up to CEO, that means when we are prioritized for PPE as healthcare workers, we selectively advantage the white folks who work in our industry over the folks of color who work in other essential industries. And that's unjust. And so healthcare organizations should try to collectively negotiate with other essential laborers and other industries to ensure that the spread of PPE and distribution across our country captures the racial breadth and diversity that lives here. So I think, to end on, that love should be the metric by which we measure our health system's performance. It should be how we determine whether our delivery structures are effective and how we capture the impact of the care we are hoping to provide. So I want to save us time. We still have about 16 minutes so that we can jump into the discussion. But thank y'all for listening to that.
Thank you so much, Dr. Boyd, for a very, I would say it's a great broad overview of the issues, but also a lot of detailed, very actionable ideas and some quite novel ideas. I'm seeing some things coming in the Q&A, but before we go into the question and answer, I would like to introduce our panel, because we actually have asked a few people to join you for the conversation that follows next. And before we jump into that, a couple of those people will talk a few minutes about their work. So as I am opening up the board here and get people to join us, let me introduce Dr. Marcia Treadwell. Dr. Marcia Treadwell is a psychologist by training and a health services researcher at Boston, Benioff Children's Hospital, nowhere close to Boston, Oakland, and co-chair of the cross-campus BCH Diversity, Equity, and Inclusion Committee. She's gonna share some data on her work. And after that, I will introduce everybody else on the panel and we'll open up the Q&A. How does that sound?
Thank you. Thank you very much. And thank you so much, Dr. Boyd. I can't wait to get into the discussion, so I will be brief. I just have a few slides to update everyone or refresh people on the work of the Diversity, Equity, and Inclusion Committee that, again, is a cross-campus initiative. And again, I'll go through things quickly. So for more detail, please visit our website. As Dr. Boyd pointed out, it's important to start with our definitions. So the diversity aspects of what we're doing is really looking at characteristics, perspectives, and life experiences that define us as individuals. The equity aspect as fair treatment, access, opportunity, and then inclusion, creating an environment where all individuals contribute fully and are valued, engaged, and supported. So the Benioff Children's Hospital's Diversity, Equity, and Inclusion Committee was conceived of in 2017 by 2 health policy fellows at the end of 2017. And in May of 2018, we had our first meeting. We worked hard with task force teams and ultimately distributed a needs assessment to faculty and staff in November of 2019. Leadership supported the hiring of a program manager in December of 2019. And due to COVID, we were a bit delayed in presenting the results of the needs assessment, but we did that in May of 2020. And then in June, we had town halls and moments of solidarity because of all that was going on in the environment around us in society. And so our work has been steady over this period of time, but it's really accelerated in this past month. And our mission and vision statements, again, are on our website. So I want to get into our actual work. We have 3 task force teams as well as a steering committee. Our education task force team has the goals to provide leadership, faculty, staff, and trainees with information, strategies, and tools to help lead in diversity efforts. The patient care task force team has its aim to reduce disparities in health outcomes and care delivery. And then the workforce task force team has the goal to assess diversity in the workplace at BCH, appraise best practices, and then apprise leadership of those practices. And our leads are one from San Francisco for each task force team. So Dr. Meyer from Oakland, Phyllis C. Stanley. For patient care, Lauren Sanchez from San Francisco, Alvin Hendricks from Oakland, and workforce, Stephanie Brown from Oakland, and Alvin Ozawa from San Francisco. Our needs assessment results, again, were quite timely. When we did end up releasing them, again, delayed due to COVID-19. So the data collection was 10 leadership team interviews, but distribution of a survey to over 2,000, almost 3,000 employees, and we had a return rate of about 55%, so quite a good return rate, even though all employees did not actually get the survey. The people who responded were 54% people of color, 76% female, and 70% heterosexual. So key findings on the positive side is that most expressed they felt welcomed, that DEI is an essential part of our mission, and most felt respected. However, there were very large disparities among ethnic, racial, and sexual orientation subgroups, such that African Americans definitely did not feel these positive vibes from BCH. And then further, only 55% of employees or people who complete the surveys felt that the current state of BCH is actually equitable, particularly with regard to the opportunities for people of color to advance, to be recruited, to be retained, and mentored. And only 65% felt senior leaders and managers were role models of diversity. And about half really observed and experienced excluding behaviors, with this happening more for people of color and people who were not heterosexual. The survey was meant to look at diversity, equity, inclusion, very specific questions that Enact leadership helped us develop. But comments raised an issue that was not a part of our survey, and that we need to do more work to integrate the two hospitals effectively into a single system. So as I said, our work has accelerated. We have a strategic planning retreat tomorrow. It was planned previously, but our focus is going to be much broader than our original intention, which was about the work of the task force teams. But now we've really been mandated by our leadership to come up with institution-wide plans and strategies, which we're very excited to do. And we'll be working on that tomorrow. We'll present our ideas to leadership on Tuesday, and then we'll implement our work. So as I said, we're quite accelerated. But all along, we will be integrating, collaborating, and coordinating across the many initiatives that are happening at UCSF, including what you'll hear about shortly from Dr. Martinez. And I really appreciated what you ended with, Dr. Boyd, as far as the importance of love. And so Black Lives Matter is just the minimum. And all of us really need to be treated as worthy, valued, celebrated, and loved. Thank you.
Thank you very much, Dr. Treadwell. I want to introduce Dr. Alma Martinez. Dr. Martinez is a pediatrician and neonatologist at UCSF, a long-standing educator, has done a fantastic amount of work for the School of Medicine and increasingly over the past few years for the pediatric residency at UCSF. And she is the Director of Diversity, Equity, and Inclusion for the Department of Pediatrics. Alma.
Thank you, Sandrine. I'm very honored to be here today. This has been an amazing time to sit and listen really carefully to Ria and to Marcia as well. The work that we're doing at UCSF on the West Campus, I think one of the big things that is coming out of all of this is the need to really have more collaboration between our two campuses. There are so many people doing wonderful, amazing things at Oakland that we need to tap into, collaborate, and learn about. And when Dr. Hirsch asked Jyoti Marbin and myself to form a task force for our Department of Pediatrics, that was one of the initial things that we did, was to reach out to Oakland to learn about what was going on the East Bay campus, in order to not reinvent wheels, and also to remove the use of silos that we've all traditionally done in medicine. I have to say I've been overwhelmed in a really wonderful way with over 90 faculty, residents, and fellows that have emailed and wanted to join our task force. And we are in the process of developing subcommittees for those task force after meeting with Marcia and Zareen Noor, who's also at Children's Oakland, to determine which of those subcategories or subcommittees would not conflict with the work that the DEI is already doing in the Trans-Bay collaboration. So more on that. I will be sending task force volunteers some updates on that, but also welcoming people to join our diversity committee. It's not just a resident diversity committee. It is resident-led at our Mission Bay campus, but we have faculty and fellows that are also working together and collaborating with the residents on a number of projects. And I I just want to stop there so that we have maximum time to hear people's questions and to hear a broader discussion of things that Ria Boyd has told us today and given us a lot of fruit for thinking about next steps. So thank you.
Thanks, Dr. Martinez. And before we go to the Q&A section, some questions have come in. If you are in the audience and you want to ask questions or comment on things, please use the Q&A function at the bottom of your screen. Before we go there, I have to introduce two more people who are really important and in this conversation and who are joining the panel. One is Jyoti Marbin. Jyoti is also a graduate from our PLUS program and currently the director of the PLUS program. And for those of you who don't know, PLUS stands for the Pediatric Leadership for the Underserved. It's a special program with its own match in our pediatric residency program. And under Jyoti's leadership for the PLUS program, but also as Director for Recruitment of the residency program, our proportion of underrepresented minorities in the residency has gone up dramatically. I don't actually know the exact numbers of the incoming intern class, but we're seeing numbers of 30 to 40% in our match rate. So she's doing a lot of really important work for the residency in this regard. And so I thought it was important to have her on this panel. And then we also have Felicie Stanley. Felicie is a medical social worker at Benioff Children's Hospital, Oakland, particularly in oncology, and a co-chair for the Task Force on Education for the BCH Diversity, Equity, and Inclusion Committee. And Felicie, who has experience with the town halls that have been going on Tuesdays at noon across our campus, has graciously offered to co-moderate so that we can handle all the questions that are coming in. So I want to start by just acknowledging a few of the comments that have come in, and then we will direct it to some of the questions. So first of all, Dr. Boyd, lots of comments that say, fantastic lecture, thanks for such a comprehensive overview, and for some novel ideas, incredible session. So people really loved it. A comment by one of our pediatric hematology oncology doctors is actually that there is a lot of evidence in even the NIH and our local research centers for the structural racism. If you take, for example, the amount of funding that's being allocated to sickle cell disease versus cystic fibrosis and compare that to the number of cases. So that's something that I wanted to call out. I'm gonna start with one of the questions, and then I'll hand it over to Felicie to take one too. One of the questions is really about your presentation, Dr. Boyd, and is there any preliminary data on the demographics distribution of COVID-19 between protected versus less protected essential workers? Have you seen any of that?
I haven't seen like papers that specifically ask that question, but I think we could surmise from like outbreaks in meatpacking plants, for example, that then paid workers to go in after there already were known outbreaks, which is essentially a form of coercion to go into a workspace that they knew was unsafe, that meant that workers who work in our critical supply chains, like the meat industry, are being disproportionately exposed. And we know those workers tend to be, as I said before, folks of color, particularly women of color. I think here in California, I would have the same concerns about migrant workers who work in our food supply chains here, who are again placing themselves in harm's way to continue to go into the workplace without the same PPE that we have in healthcare and without paid sick leave or hazard pay for being there.
Thank you.
So another question that's come in for you to clarify, Dr. Boyd, is if you could talk about our national spend on healthcare and how that number is calculated. One of our attendees was saying they weren't sure if that number reflects the cost to the government or also includes the crushing individual costs that so many of us, our patients and communities, experience.
That's a good question, and almost like maybe like a philosophical or ideological question you're posing here, because frankly, those numbers reflect like system spends. So when we say that like healthcare spending is like 17% of our GDP, that's spending that is capturing dollars that go into and out of hospitals and clinics between insurance providers, right? It's calculating those types of costs. It isn't capturing the actual costs to the rest of us to participate in this system, and particularly the disproportionate costs on folks who are overburdened by our system and the way that it's set up. So I think I said that maybe it's a philosophical question, because that choice then to prioritize looking at the costs just to the system itself without putting parallel the costs to the rest of us, I think is, it reflects our values as a system, which is less on what's happened to us as human beings and more on the profit structure of the organizations that we work for. I would love to see the other data. I mean, there is a wealth of data about how, healthcare costs are the number one cause of bankruptcy in the country and how expensive healthcare is in general. But I don't often see those figures side by side.
There's a question about the BCH DEI committee. I think this is for you, Dr. Treadwell, or for Felicie. Is there resident representation on the committee? And if not, how can resident voices be heard as changes are proposed?
That's an excellent question. There is resident representation on our committee, and I believe that the new task force will specifically focus on residents as well. So, but we have a website if you would like to apply to be on the DEI committee, and there's an application form for membership. So you're welcome to join.
So there's another question here that's asking Dr. Boyd, what impact on life expectancy do you see as a part of it, the apparent lack of respect and or disregard of younger individuals and white or any color populations for the older and especially the elder populations, now manifested by not wearing masks to prevent their own infections that might be transmitted to others?
Wow, there was a lot there to unpack. I'll say I haven't seen particular data on life expectancy related to that, but I think there is a growing concern. So one of my projects, the California Children's Trust, is looking at mental health access in California. And one of our concerns is that youth were saying we essentially don't trust adults, that like climate change and voter suppression and what's happened to our economy and to our federal government in general has shown that like the current generation who's in power doesn't care for everyone the way younger folks tend to care for their peers. And I think as pediatricians, it's really important for us to tap into that sense that adults need to stand up and show that we care about other people than just ourselves and other people who look just like us or who have jobs like us or the same privileges we have. And that is a really important modeling behavior for young people. And one quick way to do that is to stop using age-based risk profiles to say who really is at risk for COVID and why we're trying to protect certain people. We're really trying to protect everyone. And because this is a novel virus, although kids aren't as affected now, all of our concern obviously is that kids will eventually be affected. And with the, multi-system inflammatory cases that we've seen, there already are concerns that certain kids are more affected than others. And data out of London suggested that of their small population who had it, it was predominantly Black kids in London. So I think we are worried about kids. And as pediatricians, I hope we spread our voices publicly to say that we are taking these efforts also to protect them because we care about them.
Thank you very much. Let's see, there's a loaded question here. That's always a good one. What are your thoughts on where we are with healthcare providers and mandated reporting laws, particularly on issues like CSEC, which I always forget what exactly it stands for, but I think sexual exploitation of children?
Yeah, commercial sexual exploitation.
Oh, commercial. Like, what does the C stand for? This is being debated nationally, particularly given one of the reporting agencies is law enforcement, who are not always trauma informed, can sometimes do more harm than good, and our ultimate priority as healthcare professionals is to not do harm. Do you feel such laws need to be evaluated or changed, taking into consideration what's in the best interest of the child, youth, and families? That should probably not always be a law enforcement response.
This is a brilliant question. So just yesterday, the Oakland School Board had a meeting for a resolution that was brought by Black Organizing Project, which is a community-based organizing group in Oakland that had been working for 10 years to get the police out of Oakland schools. And they created a new resolution named after George Floyd and his legacy to finally bring the police out of schools. And one thing that their parent advocates said on the call is that what happens when like mandated reporters in schools are teachers, and the violence that kids are being exposed to in schools are also from school employees, and they don't report those forms of violence to the same networks. And it's a profound question that the other director of BOP said, part of the problem with how we confront our institutions and their racist failings is that we get so comfortable in relying on institutions, we still depend on them even when they hurt us. And I think that is absolutely true for policing, and I think that can also be seen in healthcare. And so I think as fellow professionals, and for folks who work in public health, who are also city employees, just like police are city employees, having those peer-to-peer confrontations to say, hey, that actually is a harm that we all need to be doing something about. And luckily we can say that, the school board passed the resolution and, they will no longer have OSPD in Oakland schools, which is amazing. And hopefully other schools across the nation do the same thing. But this question, I think, so well frames why it's a risk, because we allow it to happen under our noses, even though there's mandated requirements that we wouldn't let it happen. And so we all have to do something about that. And I think Oakland schools just gave a great example of what we could do.
Thank you. I'm gonna give the panelists a moment to ask some questions. We have a few more questions on the chat, but Josie, do you want to just pose your question yourself?
Yes, absolutely. Ria, thank you so much for spending time with us today. My question to you, and I read about this in your beautiful piece in the New England Journal, Stolen Breath, which everyone should read if you haven't read it. Thank you for writing that. My question to you is, what is your charge to us, to UCSF as an institution, as a health system, in recognizing and addressing structural racism in our own home? And I think as I'm excited about the anti-racism task force that Dr. Hirsch has charged us with putting together. And I'm also a little worried, frankly, about sort of the allure of incremental change and not really making structural change. So I would just love to hear your thoughts on that.
Thank you for saying that. The first thing I'll say is no low-hanging fruit. No longer say that this is too big a problem for us to start addressing. Let's do the low-hanging fruit. Like when anybody ever says to me in a conversation about racism, let's focus on low-hanging fruit, the first thing my mind thinks of is strange fruit. Do you guys know that poem by Aber Meerpool that was popularized by Billie Holiday when she sang it, that talks about Black folks are the strange fruit hanging from the poplar trees in the South? Like that's what I think of when people say, oh, low hanging fruit. Like and part of what we tried to frame up in the New England Journal piece is that COVID-19 happened and we switched everything on the spot. We switched where we deliver care, how we pay for the care we deliver. The governor Newsom said that telehealth is now covered by every form of insurance, like immediately. Payment models, delivery structures, who can be a provider, and their scope of care changed overnight. So never say to me ever again, if I'm sitting in a room, and to any of these folks working on this panel again, that we're only going to focus on low-hanging fruit, as if we can't systemically change how our systems work overnight, because we absolutely can. And that means that health systems like the UCSF have to get into the fight for broader supports. We have to be advocating for mandated worker protections for folks who are outside of our industries as a health intervention. We have to be prompting and promoting single payer healthcare so that we are no longer a for-profit based system, even though that's the system that props up all of our lifestyles. Like, we can't have that anymore. That having an insurance-based system makes people sick. And as long as we support it, we as healthcare systems are also invested in perpetuating racial health inequities, and we have to own that. And the last thing I'll say is desegregate our workforce. Any workforce from trainee level to CEO that is predominantly white at every level is not meritocratic. It's not even statistically possible. That means that there are criteria we're using to select people to join our workforce that advantages white folks over everyone else. And any of those criteria we see, we have to just snuff out and take out.
Thank you.
So Dr. Boyd, I know that one of our other panelists had proposed a question to you. She said, you commented on the issues of age and race. What are your thoughts about the impact of the loss of so many Black elders on the Black community? What should we be aware of as we work with impacted families and children moving into the future?
It's a great question. And first I'll just say, I know I'm really passionate about all these answers, but obviously I care a lot about this stuff. So another figure that we didn't go over in this study is the years of life lost for Black communities as a result of COVID-19. This is taken from that same study that looked at the age brackets that are most affected by COVID-19, that have the highest death rates. And what they found is that to date, the paper just came out last week, to date, over 45,000 years of life have been lost per 100,000 folks. So this is on the order for the whole population of millions of years of life lost. But if you just look at per 100,000, that's like 45,000 years of life lost, millions of years of life lost. Like, we have lost elders, we have lost parents, we have lost young people. The first Black child to die in Michigan was a Black little girl, Skylar Herbert. We have lost children. There's bereavement data that shows that Black folks have really high, because premature death rates are so high in Black communities, Black folks have high rates of losing multiple people in your family. Of children, Black children are 3 times as likely to lose a mother by age 10 as white children. Like, we lose a lot of people, and the cumulative effect of that loss, we are not even close to capturing. It is not captured in the economic data. It will be captured in the relational data, in the social cohesion data, in what happens to our populations as we are exposed to the world without the buffers of the humans who love us. I love that point you made, Ms. Treadwell, about Black Lives Mattering being the bare minimum. Like, we are in a world that is literally anti-Black in every scenario, and we're losing the people who love us. That is why we ended that New England Journal piece with Black people are loved. That is what we're up against. And I don't mean to get emotional, but that is what we are up against. And that's why our systems of care have to ensure at every level that every time a Black person enters our care, they feel loved.
Thank you, Dr. Boyd. I think that rings very true and really hits something for all of us. I want to just highlight a couple more of the comments that say how amazing people feel this presentation has been, and the comments heartfelt. Thank you for your hard work and the energy you put into this. There's actually someone here that asked if you can please run for office. So there's an endorsement. And one of our ICU fellows, actually, I think she wants to make sure you know who she is, because she puts her name on it. April Edwell says, "This is fire. Thank you for your clear presentation and your charge for all of us." So I can see how much passion there is in this and how much emotion. And I just wanted to really reinforce how much it means to all of us that you're doing this. And please don't stop. I'm going through the questions. There are a couple more questions if you're up for it. There is one question here from one of our case managers about what are some methods we can help to address those in the Black, in the indigenous population and people of color communities who have a mistrust of the medical system.
First, I want to say I called you Miss Treadwell, and it's Dr. Treadwell, and I absolutely apologize for that. Will you read that question again? Sandrine, I'm sorry. About mistrust.
What are some of the methods we can help to address the people in Black, indigenous population and people of color communities who have a mistrust of the medical system?
Okay, let's get into mistrust for just 1 second. Another paper that's hopefully coming out soon is going to come in Health Affairs, and it's going to talk specifically about, in one of the sections, how we've used mistrust as a way to describe causes of racial health inequities. And I just want to say that although Black, Indigenous, Latinx communities, immigrant communities have disproportionately borne the pain and violence of experimentation that leads to mistrust in communities, and although it's definitely true that mistrust shapes health utilization behaviors where people may delay or refuse care, trust is not the primary barrier between patients and equitable care or good health outcomes. And we can never pretend that it is. Because if we look at the history of the study of mistrust and healthcare utilization, what we see on the other side of that is we have innumerable interventions that aim to increase patient trust while leaving the rest of our system intact, while not acknowledging that these racial health inequities are not malfunctions or aberrations in our system. They are byproducts of our system functioning as designed. And that's not from any radical. Don Berwick said that, right? Who's the head of IHI, who used to work at Harvard, who used to work at CMS. Like, everyone acknowledges racial health inequities come from our systems working as designed. Trust won't fix institutional systematic problems. And so I don't typically like to even talk about trust in when I talk about racial health inequities, because the real problem is racism. And once we fix how racism harms people, then people can trust us. But trust is like the benefit on the other side. We have so much more that we have to do before we are even worthy of folks' trust. So that's how I usually approach trust when I talk at the systematic level. One-on-one, when I talk to my own patients or my own family or people that are in my own life, I do think it's important to try to create buffers for experiences of racism in their own care. So I am often on the phone with my family when they're in health visits. I make myself available to my friends and peers outside my regular job, because it's important to have an advocate on your side for who knows what the quality and standard of care you should be receiving is. That's not so that you have more trust in the person who's giving it to you. It's so that you have more skills on your own side and tools at your direct disposal so that you get equitable care in the moment. Again, it's that they don't have to have trust in the system, but they can have a trusted person like me walk them through the system so that they can get what they need and deserve. And many of us, I know, pose that role or play that role in our families and our communities. And I think it's an important role to play on the side while we also try to tear down how racism harms folks.
Thank you so much, Dr. Boyd. Another question from one of our attendees today. They said, in the current movement in the wake of the murders of George Floyd, Breonna Taylor, and other Black men and women seems to be particularly strong at the moment, perhaps because of the distant zeitgeist of COVID and the economic collapse. Dr. Boyd, what is your sense of the longevity of this movement? And do you have hope that this time the white supremacy of our system may truly shift?
The hope question always comes up. And I've been sitting with the hope question because I'm in a few panels. Many of them are other you know, Black female scholars who I just am so obsessed with and honored to just get to talk to. And I have always been more like, you know, why do we have progress narratives when folks are still being hurt? And yet, as my colleagues have said to me, and as honestly my mom said to me the other day, like, I, as an African American, am from a tradition of ancestors who are world builders to the extent that they envisioned and worked for the freedoms that we have now, right? Like just on June 19th, we celebrated Juneteenth, which was the end of slavery that happened years after actually the Emancipation Proclamation, when Union soldiers actually made it down to Galveston, Texas. And so that moment was a moment when the law had changed and people still weren't free. And we live in those moments still right now, right? Laws still have changed and we still aren't fully free. And if anything gives me hope, it's that people have been working for centuries to put us to this point. And I think what makes me optimistic about this movement continuing is that those centuries of work is working. There was a time when to talk about the abolition of the police was so passé. You couldn't do it, especially not in a respected institutional forum and not a place like medicine. But that we are now talking about abolition is absolutely the result of work that began post-slavery and includes, you know, leaders here in the Bay Area, like the Panthers and Angela Davis. Like, they created language that young folks are using now, and that's what gives me hope. I hope the work that we're all going to do in our professional careers and the work that y'all are doing at UCSF creates a future where folks are more free than we are now, to the degree that we couldn't even imagine it. Like, I'm sure enslaved folks couldn't imagine, you know, a person like me with my hair looking like this, talking at an institution like UCSF, you know?
Thank you. There's one more question that I think affects the entire panel that is important to address. And that's, given the data Dr. Treadwell shared on the experiences of Black employees at the Benioff Children's Hospital, can the panelists share thoughts on the impact of racism on Black people working in healthcare? What must we do as an institution and as an industry to address the impact of anti-Black racism on our colleagues? And so maybe I can ask Dr. Boyd to take the industry part of that question, and Dr. Treadwell follows together with Dr. Martinez and Dr. Marvin about the institutional piece of it.
Absolutely. Like, just point blank, we have to remove police from our hospitals. Like, to know that the setting where you get medical care when you are at your most physically and emotionally vulnerable is not a sanctuary for the violence of police surveillance and physical use of force it's an abomination. We have to make sure, just like I am advocating that we have police-free schools so that our kids can learn free of police surveillance and violence and discipline, like, we need police-free hospitals where people can actually get well and be healed without the threat of police that they also face when they leave the hospital. I think hospitals have got to be that sanctuary, and I hope UCSF considers leading the nation in becoming that type of a sanctuary.
Thanks. And I wanted to really say, Dr. Boyd, how inspired I was by your comment that we can do it. So this idea of the incremental changes needs to just be thrown out at this moment in time. And, you know, as we've had more of these anti-racism discussions, when Black people hear about the White Fragility, you know, that book, it's like, it's so validating. And so all of these years, you know, African Americans, Black people are in this system and have been told, you know, we're too sensitive, we're this, we're that. It's you're misunderstanding. That wasn't my intention. And so when you bring the white fragility into it and the anti-Black racism component, it becomes really clear, again, that people can and need to change and not put the onus on the people of color to make these changes. So for people of color in healthcare, I would just say that we do have to take this moment in time. I do share the optimism of this moment in time to move us all forward and really make radical changes. We can't wait any longer. We can't go slowly. We have to validate in the same way the lives of our healthcare providers of color, because the trauma, you know, we live all of that trauma of the children and families that we see in a really different kind of way, I believe, than the white providers. And so again, I just think that this is the moment in time where we have to change and really demonstrate and live the value, the way that we value all our employees of color.
Thank you. I also want to add some comments to this, and I think that's part of why I'm really excited about the task force and about working with my colleagues at Children's Oakland as well, that we need to become humble as clinicians, as physicians. We need to learn. We need to listen to people. We need to educate ourselves and not rely on all of the experts to do this for us, but we need to actively be involved in our own education and acknowledging our own biases, our own racism, our own microaggression. And that's part of what the task force is going to look at, examining in the different areas, faculty, trainees, leadership, and cross-Bay collaboration, where we can educate our faculty, our residents, our trainees, learn how we can stop what we've been doing all along, and really reflect on how it impacts communities, our learning communities, but also our patient communities. I'll tell you, recently I had a meeting where I thought it was going to be just a meeting to talk about toxicology testing in our unit, and we didn't even get to the nuts and bolts of the toxicology protocol or algorithm or whatever you want to call it. We just started talking about racism in how it's been used in the past and examining our roles in following protocols in the past without even thinking about, are we really doing something that will ultimately protect this child? Are we making things worse for this child? And so at the end of the day, it was probably the most powerful meeting I've ever attended. We didn't do anything that we thought we were going to do, but we just talked to each other and listened and reflected on how we were involved and how we've been involved in doing things that were harmful to communities. Yes, we did try to protect children, but yes, we were also causing harm. And so, and now there's a whole new process, and how are we going to move forward with this? We haven't figured it out yet, but we've stopped what we've been doing, and we need to think about it. And I think that's what all of this is teaching us. We need to stop and listen, reflect, move forward slowly and with others, holding hands and figuring out what's the best approach.
Thank you, Alma. We're coming towards the end of our time, and I wanted to give Dr. Marmon just a minute to maybe say something about the efforts that you have undertaken to educate our residents and increasingly our faculty in these topics.
Yeah, absolutely. I don't feel comfortable having the last word. I feel like that should go back to Dr. Boyd for the last word. But I appreciate the chance to say a few words. I think in response to that question as well, and I think this ties into what you just asked, Sandrine, I think part of what we need to do, we absolutely have to do, is recognize the impact that hundreds and hundreds of years of inequity have had on the people who are in our workforce. And we have to recognize that we cannot continue to do business as usual. So I think that's part of the power of the diversity committee that Alma and others have been working with. At least on the San Francisco side, we've had such a robust involvement from the incredible residents who have been involved in leading that committee, and then involvement from faculty and fellows as well. And so some of the things that we've been talking about doing, one is we've been working on developing with a very large, incredible team, a new DEI curriculum for the pediatric residents on the San Francisco side. And so we'll be doing things like microaggression simulations to try to give people some tools and language and practice, just like we practice other types of medical procedures. We want to practice interrupting microaggressions as an intervention, as a way to disrupt what's normally happening. We've also been working on training a group, or we will be starting to work on training a group of faculty who have volunteered to be diversity, equity, and inclusion catalysts. So these are people actually from across Oakland, San Francisco General, Mission Bay, and Mount Zion, faculty members who are committed to doing some training themselves around facilitating conversations around race and racism, and then trying to work towards creating a more inclusive learning environment so that we are able to have conversations about bias and the very real impacts that we see on our patients and on each other when there is bias happening in the clinical environment. So those are a couple of the things. I think the other thing that I think Leanna Lewis may still be on the call, but Leanna is an incredible person who's been working with us on offering race-based caucusing. So we've been offering opportunities for residents to gather by self-identified racial group to talk more about their own specific experiences with racism, and then with power, privilege, allyship. So those are some of the things that we're trying to do to help support building an inclusive learning environment. A lot more work to do, and we welcome any involvement.
Thank you, Josie. We are at time, but I wanted to give Dr. Boyd an opportunity to say a last word before we close this very special last grand rounds of the academic year.
I just want to thank y'all again for letting me come and be my full self up in here and show you how much this issue means to me and so many of us. I just really appreciate y'all. Thank you so, so much. This was an honor.
Well, thank you. And this conversation will continue. We are co-hosting grand round sessions around topics like this. We can't wait until you run for office, Dr. Boyd. And once you have your whole agenda laid out, we will have you come back to I don't know if that's against any university rules to do political campaigning during grand rounds, but who cares? We'll deal with that. Dr. Hirsch, I think you're still on. I don't know if you want to say some closing words.
I'm still here, and I just want to, first of all, thank Dr. Boyd and the entire panel for a really absolutely compelling grand rounds. And I have to say, for me personally, the one thing you said I thought was most compelling was your comment around low-hanging fruit, that there is nothing that we can't accomplish, and we should set our sights high to do the big things. So thank you for pointing that out to us. One last comment before we close our series for both Sandrine, the fiscal year and the academic year, and that is that I want to thank Sandrine for what has been an exceptional grand round season. You have elevated the quality of our grand round series just amazing, and it's reflected in the high level of participation that we've had this year. There were over 300 people participating today, but in general, participation has been phenomenal throughout the year. So I'm looking forward to an even better year next year. But Sandrine, I really want to applaud everything you've done to create this great season for us. Thanks, everyone.
Thank you. And just so that everybody knows, Charisse is actually behind the scenes making a lot of this happen, and she has recorded this. It will be available. If you do not get the emails from Charisse, I'm the only Sandrine at UCSF or in San Francisco, so as long as you know how to spell my first name, you can find my email address, and you just shoot me an email and I'll get you the link. Thanks again, everybody. Thanks, everybody on the panel. This was fantastic, and we will do it again. Thank you.